from outside hospital. There's a history of a couple surgeries here, but the main thing to appreciate is the construct. The lumbar construct has S1 screws that have clearly failed. So the plan for this patient, given the hardware failure, the coronal deformity, was a multi-stage intervention with hardware removal, followed by lateral and ALIF cage placement, and then followed by posterior fusion. So the hardware removal was uneventful. Lateral interbodies were placed from L1 through L5. And then the ALIF was performed at L5-S1, but unfortunately it was complicated by a venous injury. So the final stage, the posterior instrumentation, was delayed to facilitate recovery of the patient's H&H. Neurologically, she was doing well. Unfortunately, about a month afterwards, imaging revealed that there was cage extrusion. And I'm sorry, we don't have very high quality imaging from 10 years ago, but you may be able to appreciate, especially on that lateral x-ray, that the cage is almost entirely out of the inner space anteriorly. A T10 to pelvis was performed. There was some discussion with the patient about retrieving the cage posteriorly or trying to pull it back into the inner space. That wasn't successful, and just a routine TLIF was performed. The ALIF cage was left in place. The patient did very well for many years, and she's coming back to us now because she developed cervical radiculopathy. There were some signs of this 1 year post-op from the interventions I just showed, but that was managed conservatively with PT and traction, and she did very well. But now she's coming back with the images on the left there. You can see progression of the degenerative disease of the C-spine, and now she does have a motor deficit. Patchy throughout the upper extremity. She's got a little bit of hyperreflexia on the left side as well. On top of this, she's developed a little bit of PJK and degeneration above her prior construct, although she appears to be asymptomatic from this. So now we're faced with the surgical decision. We need to decide whether to proceed with cervical intervention, thoracic, which to do first, or whether to operate on either at all. And then anterior versus posterior, the quintessential question, and then finally whether or not to link the constructs if we intervene on both regions. So that's the current state of this patient, and we're actually planning on performing surgery today.
So my microphone's not working. Bob.
If you want to come up here, Dr. Chapman, maybe you can.
You may have to improvise there.
Good morning, Jens Chapman. Great presentation. Can you go back to some of those imaging studies? Bob, I know as a leading member of the ISSG, you have done a yeoman's work at identifying alignment and construct stiffness and construct alignment and over and under correction and balancing of the spine, which is really important work. Have we overlooked something as we look at failures in patients? And again, there's obviously a visual problem with that extruded ALIF cage, but the general construct, I'll ask you, I'll just stop there, have you comment on that and the number of interbody fusions, but have we missed something important? If you go forwards again, there's something else going on. If you look at the signature of the cervical spine and then the thoracic spine, this looks like an inflammatory arthropathy to me. This has nothing to do with the instrumentation there. So can you comment on the multimodality of adjacent segment failures beyond alignment issues?
Well, it's, that remains one of the great unsolved problems, right, in spine, and the effect of spine fusion is adjacent segment. And we used to call a patient like this, I think, is a little bit of a spinopath. That's what one of my faculty would have called this. Her cervical spine looks the way it is, not because of what was done at the thoracolumbar spine. This, in my opinion, there are alignment issues that translate. So obviously bad alignment in thoracolumbar junction or thoracolumbar spine does translate into bad alignment in the cervical spine, compensatory bad alignment. So there is that. But I actually think the thoracolumbar construct that she ended up with looks pretty good. I would not have gone back and retrieved the cage either from the front or the back. I think that was really good decision-making there. And the end result, I think, looks quite good. I don't think I would have done the procedure that was done here of hardware removal followed by all of the X-lifts, but it worked. And obviously her coronal alignment turned out better. And I think most importantly, her sagittal alignment looks very good. And if you look at her, the adjacent segments in the thoracic spine, there's undoubtedly some mechanical effect from just the stiffness of the remaining thoracolumbar spine below. But I mean, a 10-year durability of this construct in a patient with obviously some tendency towards disc degeneration, I think this is a nice outcome. So I don't know whether I would go to T10 now. I kind of think I might. Clearly the cervical spine, the options that were laid out, you got to do the cervical spine. So I wouldn't argue against doing the cervical spine and leaving a gap from T2, say, to T10. But I also would not argue against doing the whole posterior construct and linking it up. I think the effect of motion loss is not going to be that substantial. I suspect you'll be back at a certain point, potentially, and maybe likely be back at a certain point, even though it's relatively asymptomatic. It just doesn't look good, obviously, not headed in a good direction. So.
Dr. Hart, let me ask you a purely theoretical question. I'm not sure that any evidence exists in the literature for this. By doing the thoracolumbar fusion, you're robbing the patient of some element of flexibility. So the rest of the spine, as the patient looks around and lives their daily life, has to assume the responsibility for movement and all the standard motions you do on a daily basis. Would someone who has a propensity to degenerate like this patient, would that still maybe accelerate things a little bit in the neck, even though the alignment is good?
Undoubtedly, it probably does. So there's added wear there. I think that's, though, pretty much in the noise. But your point is a good one. She probably uses her neck more because she's unable to use the lumbar spine. So I'll accept that. But one further comment I would make is, and I've had a few over the years that have ended up with C2 to pelvis fusions. If that's avoidable, I think that's a good thing for the patients. In this lady's case, her cervical spine is so badly affected. I think you've got to fuse the entire cervical spine anyway. And I don't think those intervening segments really leave you much much added flexibility. So, yeah.
So we just have one microphone, so we have to reach it around here. So if I look at your clinical exam there, is the prerogative of concern right now focused on the the cervical spine, the upper extremities? Is there more cervical myelopathy, or is there a thoracic myelopathy? I don't see much that I can deduct from in this exam.
I have to admit I haven't seen this patient myself, but it seems like the majority of the symptoms are cervical.
Okay, and intrinsics, so C71 subluxation, grip strength, hand intrinsics, left versus right, cord signal changes. Kind of talk us a little bit through what you're seeing here and how you align that with the exam.
I mean, given the imaging, and I'm sorry, I don't have the axials available here. I'm personally most surprised that she only has a trace amount of hyperreflexia. I would expect this patient to be more grossly myelopathic in the lowers. The focal findings I think suggest that the areas of worst pathology are lower down in the C-spine, and that matches the imaging. Certainly, there's the slip on C71. And I'm not showing the foramina here, but there's definitely some element of foraminal stenosis at that level and the adjacent levels. I'm not sure with this amount of degeneration that we can necessarily make focal deductions, but it's pretty clear that there's some element of myelopathy going on as well.
And whenever I see this kind of, for instance, especially subaxial subluxation pattern, erosive end plate changes, vanishing of connective tissues between the bone, I'm wondering about inflammatory arthropathies, I said. So has this patient been on steroids, methotrexate,
To my knowledge, no. The only thing that I could find that was relevant was a history of osteoporosis.
And fingers, hips, knees, shoulders, all intact?
I haven't seen her myself, and I didn't see anything documented. Maybe
Let's pass the
somebody
microphone to Dr. Askulian. So what are your plans and why do you want to do what you want to do?
So excellent questions by Dr. Chapman, as usual. So surprisingly, she actually has more of hand intrinsic weakness, not surprisingly. She's not as myelopathic as the MRI, which suggests she's actually fairly mobile. She's just been falling more, and they just randomly got an MRI of her cervical spine. She has a history of rheumatoid arthritis, and actually operated on her like 15 years ago. And she started to develop PJK since she fell. She kind of developed, I don't know if you showed the thoracic, compression fractures, and she's been on and off steroids her whole life. And she's in her 80s. She's remarkably, she's actually mobile. She's independent. She's a retired CPA, lives in Idaho. I think the reason to do only the areas that we discussed is just because right now that's kind of what her symptoms are. But I do agree with you. I think she's going to need to have a posterior cervical fusion.
One thing, if you can go back to the cervical spine, that worries me, and maybe you can address it, Yev or Rod. She has fluid in her C1, C2 joint. Now that you've told me that she has rheumatoid arthritis, which we were deprived of before, I'm worried about C1, C2 instability. There's also some pannus. Is there a flexion extension film? Do we have any idea about the health of the C1, C2 articulation?
no flexion extension films in the system.
Yeah, that's something. Do you have a scoliosis film on her?
We have a very old one that's stitched together. It's not very high quality.
Last night.
Didn't see him, but
Okay.
we can look.
I agree with you, Jens. I think she's going to need to have down the road probably C1 to T2 fusion. The only question for me is her alignment is actually fairly good when she stands up. So I'm a little hesitant to extend it down. So what I told her is we would do the ACDF, give her 6 weeks to 3 months, get new imaging, get new x-rays. She's a really very independent and very motivated patient. So that's kind of what we're doing, the smaller surgery now. What do you think, Bob? Actually, believe it or not, we're only going to do C6 to T1 today, anterior. Just because, she's older and she's got a lot of, I just feel like if we do more, we were going to do front back, but I kind of decided not to.
I was starting to say, again, these patients that have C2 to pelvis fusions, the ISSG data, actually Hanjo Kim has looked at that closely, and it seems like they, as a group, do experience improvement after those operations, but it is a morbid end condition. And so just doing a few levels anteriorly, relieving her neurologic issues and seeing how she does, I think is very reasonable. And we've also talked, it's maybe a sort of a novel form of PJF is one of the side effects of that extensive effusion is patients begin to have falls because they can't look at their feet as they walk, and so they trip and fall. And a lot of them have ended up with odontoid fractures down the road. So I think that's a good plan.
Yeah, we'll see. We'll give you good follow-up.
Yeah, this is a thankless case in many ways due to systemic disease. Given what you're describing, I'd probably do the cervical spine first. An anterior-only fixation in a patient with rheumatoid arthritis, I'd want to see a DEXA scan, and the anchoring in T1 is going to be very precarious and it's probably going to fail or cantilever. I'd definitely do bicortical screws there and probably really do her posteriorly very rapidly. So those are some main thoughts. No great answer, but she will eventually end up with a cervical one to pelvis fusion. The intercalary segments are going to be very much at risk, and they'll just fail. And the question is, what's going to fail where first? Based on what you know right now, if you do a posterior C1 to T2 fusion? Would you do something to augment the caudal fixation level, a banding or something distally? Yeah, if you're supposed to look at that this year.
We're still working on the the biomechanical study, but I think right now there's a complete paucity of evidence in the literature. So hopefully we'll change that in the coming months.
Good. All right. Any other thoughts? Otherwise, we'll go on to the next one. Thank you, Yev. Great to talk. And we have Jared Cook. Dr. Jared Cook is going to present a different angle of deformity correction. We thank all of our viewers for being here today. And we're looking forward to our presentation later.
And there goes the pager.
Yep, this has been a very busy beginning summer. I'm not sure how it is in other places in other countries, but we've had a significant hit rate here.
Yeah.
Jared, take it from here.
Recent uptick. All right. This patient's a 74-year-old female who had a recent ground level fall directly onto her back, has a history of chronic back pain, significant narcotic requirement, and a significant surgical history. And we'll just kind of show the images that are available from that from throughout the years. So upon presentation, she's, her strength and sensation are completely intact. Her only issue is the back pain and a forward bent posture. So I apologize for this next one, but this is the only thing I have of the intact spine, because it goes back pretty far. So basically, this is her spine without any hardware back in 2007. So first intervention, and again, notes are not available from that, but first intervention, we have a 2-level standalone XLIF. The issue there is she's pseudoed, and this was addressed with a unilateral posterior fusion. So you can see where where that was reinforced. Then a couple years later, you can see it, there was collapse, so adjacent segment degeneration just proximal to that. So that was treated with XLIF and then a posterior fusions, now bilateral screw rod construct. Then that pseudoed as well. So then in 2016, she then was treated with an extension of her fusion, and then in 2022, all right, mic interference. So then in 2022, PJK as this patient's pattern. So then the solution to that at that point was to treat it with an IDO at T910, and then bring the fusion up to T5. So at that point, she's doing well, and that's when she had her fall and presented here. So what we see is bilateral rod fractures right at the level of the IDO. If you can see my cursor, so this is just showing one side of the CT, and this is the other, show you where those rod fractures failed, just below the inline rod-to-rod connector. And then I include the fluoro shot from from the surgical procedure she had. Surprise, we did surgery. So you can see where those rod fractures are. So at that point,
let's stop here for a second. So this is a ongoing topic. And good morning, Nick. Are you live? Okay, we'll wait until you're unmuted. Bob, so obviously when we have a adjacent segment failure, we don't want to tear the whole spine apart. There's a strong desire to limit the dissection just to the rostral segment. What are your thoughts in terms of trying to put an add-on connector into the spine so that we can kind of just tag on to a previous construct and don't have to tear everything apart again?
Well, it's, I think this is complex decision-making for sure, and it has to involve, in-depth conversation with a patient, regarding how much she's affected by what looks like sagittal imbalance. So you've got an acute problem here of the rod fracture and neurologic vulnerability, if not neurologic injury, and that certainly, I think, needs to be addressed. The question is whether to try to improve what's been done previously with a bigger realignment procedure below. I think if you're not going to do that, then focusing just on this construct, I think, is fine. And I have gone to a pattern that augments the inline dominoes, as was done here with outrigger rods as well, and you can put those on either to dominoes, side-to-side dominoes, or you can put them onto dual head screws, and at least 1 to 2 levels above and below the inline domino. I do like the inline domino connectors. I think they're important. That limits what you need to do. It looks like you'll have to take out the screw at the just below the rod fracture there, and I would probably replace the screws above that. So if we weren't going to do the rest of the realignment below, I would take out the upper screws, put side-to-side dominoes on the construct in the lower, in the thoracolumbar spine, and then probably replace the screws with new rods in the upper construct. And I'd have to look closely to decide whether we wanted to add on yet another level. I think if that's, certainly if it's fractured, I would. If it's badly degenerative, I probably would as well. And then attention to whatever pseudo arthrosis there is at the level of the rod fracture, which I'm presuming there is, although I don't see it here on these CTs.
Jared, did you find anything in the literature about the biomechanics? I want to come back to you in a second, Bob, about something that you said. In the literature that identified biomechanics of these end-to-end connectors, whether they're side or end-to-end connectors, is there anything that you've seen published so far in clinical medicine, at least?
Well, I mean, they're certainly weaker. The other thing is that with those connectors, not for what I'm about to say. So, what we do know is that when rods are notched, they're weaker, and the connectors will function by actually notching into the rod. So that's a concern there. That's what you're kind of referring to.
Yeah. So, Bob, the questions that I had here in terms of biomechanics, what are your thoughts in terms of how stable are they? Are they as stiff as a normal rod? Is there a weak spot? And why did these rods break where they did? Is there some cantilevering mechanism that took place?
Well, I think they're stronger than the circular rods, right? The cylindrical rods. So, and that's why they fracture at the junction, not within the domino. There are some models that have only 1 locking nut above and below, so a total of 2 locking nuts. I'm not a fan of those. I like these longer ones that have 2 locking nuts above, 2 locking nuts below, and you can see the rods meet in the middle. And I'm not aware of any biomechanics study of these either, but I do think they serve a function in reducing the amount of intervention you need to do along the whole construct.
Yeah, so that's an insightful statement. So this is obviously a more complex issue. I've personally had 1 or 2 failures where one kind of a hole connector is disengaged from the spine. So I like these 2-hole connectors much more, but clearly when we insert those, we have to kind of bend the upper end of a rod to fit them in. And I'm worried that when we do that, we may actually create what Jared said, which is a notch sensitivity in that junction zone. So I'm not sure that is a factor. In general terms, for deformity correction surgery, what is your preferred rod caliber? I know that the ISSG has published something about rod fractures, and you've presented on that, as I remember. These are 5.5 rods. Are 5.5 rods more commonly associated with rod fractures and deformity surgeries, or are they on par with 6.0 rods or other calibers?
So it depends not just on the size, but also on the material the rod is made out of. I use either 6.0 or 6.35 titanium. I used chrome cobalt for a while when that came out. That, in my hands, has a tendency for late infections in the same way that stainless steel does. So titanium is more bacteriostatic. I find it easier to work with, and I've been happy with the 6.0 and 6.35 diameter titanium, although I do use a 4-rod construct now for longer fusions. And this is an area also, kind of watch this space. I mean, there is a new rod now available, and I do have a conflict with this company. The company that manufactures it is called Miras out of Atlanta, and the material is molybdenum rhenium. Rhenium is the highest molecular weight element on the periodic table that remains stable. It's not radioactive. So there isn't likely to be a stronger type of metal, an alloy coming. So this probably is going to be the last and strongest. And they right now have a 4.0 rod. They don't yet have a 5.5 rod. They're not going to manufacture a rod higher diameter than 5.5 because it is so stiff and hard to bend. And it has much less notch sensitivity. I've used the 4.0 rod now as an outrigger rod in my first patient, and I was very happy with the handling characteristics of that. And that 4.0 rod is stronger than a 5.5 chrome cobalt rod. So it still adds the strength without the size, and you really can't notch this material, which is one of the problems that they're experiencing in terms of manufacturing. We can't put a screw out of it yet, can't make a screw out of it yet because we don't have a drill bit that will carve into it.
So in practical terms, how would you revise this now? So this patient has failed. Would you revise the anterior cage where there's a question of a delayed union or a non-union? I think remind me again, what was the delta of the index surgery that was performed here to the fracture?
4 months, 4 or 5 months.
So technically speaking, still a delayed union. Would you revise that cage also to provide more anterior column support? Number one, and number two, would you do a quad rod construct on the backside now? Would you take the construct lower down?
Yeah, again, if we've decided that all we're going to do right now is fix the non-union, which is the most acute problem and the most serious problem, then I think I would, I don't know what levels those are, but the thoracolumbar construct, I would remove the upper screw in that. I think I would remove all of the upper construct and replace those screws, and then address any remaining levels of non-union. Maybe add one level above, and my construct would be inline dominoes as you've got here, and then outrigger rods with dual diameter heads in the thoracic spine, and a pair of offset dominoes on the lumbar side, two on either rod. Right?
Where would you put the inline dominoes?
I would now domino onto, I can just show it on that. So remove these rods or these screws, and then the domino will go here to the new rod. And down here, we'll have one set of offset dominoes here, another set of offset dominoes here. And I guess that's a cross link. I'd probably have to take that out. So 2 dominoes side to side here, 1 inline domino here, 4 rods spanning the pseudarthrosis.
So Jared, what would you do? And clinically, I have to say, when she stood up, she had a severe kyphosis, so this was a precarious situation. She was developing a burst fracture on one of the CTs at least.
So most of what you said was done, including the going up 1 level. So the rods were removed down to L1. So the top fractured part just removed, and the metal cutting burr used to remove the kind of existing residual rod down to L1. Screws were replaced because the tulips would not accept a 6.0.
I have one quick question. So this is a before surgery. Cemented screws, prediction, Bob, hard to remove or not?
Usually not. If they are cannulated, fenestrated, if the cement has been injected through the screw and comes out fenestrations, then a brutal removal.
These are fenestrated screws.
These are fenestrated. in some cases, if surgeons know that, and it's important, I guess, for the fellows to understand this, if you're going to use fenestrated screws, you can you insert your screw, inject the cement, then you want to turn the screw out and then let the cement harden and then put it back in, all right? So you don't have bridging cement coming through the holes of the fenestrations. That makes removal, if ever necessary, much less of an issue.
The surgeon who put this in isn't here right now, so I'm not sure this was done, but go ahead, Jared.
Sorry, let me, I accidentally hit the backtrack button, so here's what was actually done. So yeah, so here we can see the hooks at the top, the connectors were, placed down the thoracolumbar, and so we don't have any inline connectors bridging that osteotomy site. We do have the outrigger rods, as you said, spanning that site, and then hooks up at the top. So went up one level to T4. The screws, when we took them out of the cement, there was no hole. It didn't take anything to break the cement. So upsized the screws, got a good bite, and also notably, the preoperative SVA was a little over 11, and the post-op is 6. So that's very helpful, especially for her postural complaint.
Any complaints about that or criticisms, Bob?
I think this looks like a very robust construct. I think it's more or less a variant over what I was considering. It's another variation of quad rod construct, so I certainly wouldn't have any argument with what was done here. The inline dominoes, I think you ran into a situation where you only had room for a 2-hole domino the way it looks, but that location should be okay because it's in a fused solid segment of spine.
I have something new for you, Bob.
Okay, I can't wait.
This is an inline rod. This is a unit piece.
Oh, yes,
this is
I've
not
seen this.
welded. So this is actually one piece of titanium.
Yes, good.
That has a 2-hole end-to-end connector, and it's not welded or anything like that. So the manufacturer says it's actually somehow crafted, I'm not sure how they can do that, out of one single piece of titanium. So it is actually not connected. We'll see how that holds up. It's a 6-0 rod that has a somehow gun drilled, I assume, and shaped end connector built into it. So
I've used that. I didn't recognize it, but that's a nice application of that construct.
yeah. And Rossi, we did not put a band on. We put a set of hooks on top and cables. Any thoughts in your ISSG knowledge? I know you guys have focused on that more and more in terms of that survival versus bands. Again, when I saw those spinous processes, I was not sure how I could put a band around that. Those were too puny. Those are too little, especially with the geometry there.
Well, so my favorite construct is just a simple Merceline tape from UIV +1 to the UIV through a transverse hole in the spinous processes. That was something, I think Chris Shaffrey was the first to really bring that forward. And I've had good success with that. Really, I think the key elements are alignment, which you've improved, although it's still not perfect, but it's much better. So sagittal alignment, not overcorrecting, but also not undercorrecting. Then some sort of a tether. And the third thing is that the upper end of the rods are contoured down into the most proximal point of fixation, so that there's, as the patient lies on the table, there's no pull-out force on the upper end of the construct. And I think that's something we didn't necessarily recognize as a surgical community years ago, and certainly I didn't recognize it, and used to sort of force the rod down in without fully bending it and then putting the locking nuts in, and I no longer do that in any setting. And it's still not a zero problem, but I think the incidence is, if you follow those techniques, the incidence is way down from what it was 10 years ago.
So Dr. James Babington, thank you so much for your great question. I'll keep harping on Dr. Hart here, and we'll exchange. Thanks, Jared, for your conversation or your presentation. Who's going next? Jerry, okay. So Dr. Babington asked the question of how much prevention was done in this patient: fall prevention, organized exercise, bone health optimization, given a progressive disease and fusion failure over years. Bob, can you talk about that a little bit? I mean, this is a very big topic, the prehab issue, and all too true, so fire away.
Yeah, I'm a big proponent of prehab, and particularly bone density issues, nutrition issues. These are the two, and weight loss potentially. These are the ones for me that are the primary, and I guess you can add narcotics exposure, although I think that's becoming less prevalent as a concern. But then there are patients like this one where we don't have the luxury of time, and we don't have the opportunity because of the acute problem and neurologic vulnerability. So I think it's important that we have both technical aspects of our approach and then also the management issues in cases where we can choose an elective pathway.
I want to really thank Dr. Babington for this insightful statement. He's a very experienced physiatrist. We have the great benefit of working with him, but I think not enough. Clearly, when we do fusions, as was said in the first case, we do an unphysiologic procedure. Clearly, the more patients are fused, the more their biomechanics change, their balance, their sense of daily function changes, and optimizing their muscle control, their posture is a really big deal outside of bone health, which has been a big focus. Clearly opiates don't help when you have a long fusion in the lever arm because you're far more prone towards toppling over, falling, etc., which then puts a huge strain, if not a failure point, to the next higher level. So thanks for that question, James. And again, the closer we can work together with rehabilitation, medicine, and physical therapists to try to prehab patients, the better. And certainly post-operatively, these patients need to stay on an organized program. Dr. Jerry Robinson is next, and he has a case.
Yep. Thanks, Dr. Chapman. So my name is Jerry Robinson. I'm one of the ortho spine fellows here. Today's case is a deformity case, a 75-year-old male, age 12 months of bilateral lowers, numbness and tingling with global leg weakness, and decreased walking ability. They do have low back pain, and sometimes they feel like they can't empty their bladder. They're rating their disability at a 62 ODI, considering themselves crippled. Here you can see their past medical history. It's fairly extensive, but patient did have the CABG years prior, has B-cell lymphoma, currently on active infusions with a thrombocytopenia and anemia you can see here, as well as osteopenia that's been worked up, negative 1.5 in the hips, and was a former smoker in 2013. Here you can see their exam with their labs as well. You can see that there's anemia. Their platelets are okay at 98. That's up from their baseline. And they have some lower extremity weakness. And they are in a wheelchair when they present. Here you can see their global alignment. They have a right coronal imbalance from kind of an oblique takeoff of L4-5 up to L2 with lateral listhesis. You can see a C7 SVA at positive 9.8 centimeters with a PIL mismatch of around 24, and you can see those parameters drawn on there. Here you can see an MRI, multi-level foraminal narrowing with central canal stenosis and arthropathy. Here you can see a CT, severe arthropathy with multiple vacuum discs, but no facet ankylosis, although there is an L5-S1 right lateral bridging osteophyte with partial fusion, and you can see the atherosclerotic changes of the aorta. And so plan for this.
All right. So Nick, are you live now? Are you unmuted? Not yet. Let's work on having his microphone unmuted. Nick, thanks for joining us today. We're looking forward to your presentation. So Dr. Hart, so we have a couple of issues here. We have a polymorbid patient talking about prehab. Clearly, some things have been optimized. This is a very in tune person. He's obviously had they have had significant healthcare problems. The patient is now literally crippled in terms of his spine, and the patient identified that they did not want to proceed along with this quality of life. You can see how the kind of chest is intercepted by the abdomen out to this lumbar collapse, and that's in association with severe stenosis. There's vascular disease, but not clinically relevant. That was checked. So is this a patient where we want to think about surgery? And if so, is there something that can be done that's less invasive? The eternal question, as we have this combination of structural problems, lateral ascesis, olisthesis, high-grade stenosis, and deformity and stenosis.
Well, this is a tough technical case for sure, and I guess I'm going to skip past the questions of rehab. Or prehab. We've already kind of discussed that, but clearly,
Yeah, this patient has been delayed because of COVID. They've gone through all of the appropriate non-operative care.
right, absolutely. So if we're going to talk just about the technical aspects of how would you treat this if we're at the point of doing surgery, it's plenty difficult just to focus on that. So my typical approach, so first of all, I would say I don't think you need a full 3-column osteotomy, at least not a pedicle subtraction osteotomy here. I have very infrequently done that in unfused spine because you've got the power and numbers of the multiple levels of segments that you can gain smaller amounts of correction at and get overall alignment restored. If you want to define the clinical problem, he's got really, to me, 3 issues: spinal stenosis with neurogenic claudication, sagittal imbalance, and then he's also off in coronal plane. So you want to come up with a treatment plan that's going to address all of those. I would like to get a 3-dimensional image of his thoracic spine to try to determine stopping points. From what I can see here, I probably would stop at T10 from what I've seen so far, or thoracolumbar junction. And if he doesn't have something quite degenerative or stenotic above that level, that's where I would choose as my upper endpoint. I typically do the correction from the back and then come back and do anterior inner bodies through a limited approach as needed, and typically include 5-1 in the posterior construct if possible. This gentleman seems to me like he might be a candidate for the reverse order because I'm not going to be able to do anything with a 5-1 disc by the look of it from the back. Whereas you probably can release that from the front and then gain some correction and height restoration there. So I think actually a several level lateral anterior to psoas from 2-3 at least through 4-5, and then an ALIF at 5-1, followed by a second stage laminectomy and instrumented fusion with as much as you need to do then in the posterior column to restore the alignment from thoracolumbar junction down to pelvis.
Does the presence of calcific vascular disease worry you when you do these anterior procedures? I mean, this is a pretty profound circumferential calcification.
Yeah, it probably raises the risk. I think the interval right there that Jerry is showing with the arrow, to me looks like you could get to those discs without much disturbance of the aorta. And I just said recently in another context, I've adopted the anterior to psoas type or OLIF type approach as opposed to the initial XLIF type approach that was really trans-psoas. But actually in my hands, the anterior to psoas is actually in the anterior portion of the psoas. So it's anterior trans-psoas, I'll say. So I still come through the very front of the psoas muscle, but try not to disturb much of it, and certainly don't come directly lateral, and particularly at 4-5, that's I think a critical element in terms of neurologic safety.
Great. Dr. von Halm-Lutterodt, Nick, are you live now?
Yes, sir. How you doing?
Nick?
Yes, sir. Can you hear me?
Good morning.
Morning, sir. How you doing?
Well, we'll get back to you.
While we're waiting, can I ask Dr. Hart a question? When you have a 75-year-old with these parameters, what do you think is it appropriate to age adjust or go for broke? What do you think in regards to this patient's parameters? Because I think, the data would say at like a 70, 75-year-old, the SVA doesn't need to be less than 5. It could be 7 or 8. Do you think this patient is that far off and it could be more limited?
Yeah, you don't need to match his pelvic incidence with his lumbar lordosis. And I'm not sure I believe that the pelvic incidence is only 36. It may be. I see your measurement. but that's quite low. So, so this guy, if his pelvic incidence is 36, then a non-age matched alignment would be a lordosis of about 46, let's say, slightly greater, right? Because on the lower end of average, average PI is about 55. If on the lower end, patients with low PIs, you need more than their pelvic incidence, not a match. So if we started with that as a goal, adjusting it down in this gentleman for age, you could probably accept a 40 degree or 42, somewhere in there, low 40s. So that would probably be my goal if I believed that alignment. And part of the reason I don't believe that alignment is his lumbar lordosis is limited, but it's non-zero, and yet his sagittal alignment, and you can see he's struggling to compensate, is way off. So, and 36 would just be quite low, extraordinarily low.
So Dr. von Halm-Lutterodt is going to talk a little bit later about deformity corrections, and we have really kind of shied away from these more morbid, more invasive vertebral column resections, although this is something that might have to be contemplated here. Why don't you tell us what we did here?
Yeah, so this patient underwent an all posterior T8 to pelvis with T7 hooks, a T11 to S1 laminectomy with 3 column osteotomies from L2 to L5 intradiscals with quad rod construct. Here you can see that. Fairly extensive procedure, but did get good correction, 40 degrees of lumbar lordosis at this point based on the CT scan. My apologies for the scout images. That's all we have right now for the sagittal profile.
Did you get us a coronal reformat of the lumbar spine? Were you able to put one of those on? On the postoperative?
CT. No, I just have this and the abdominal view that showed it.
So this is an eccentric intradiscal osteotomy that we did here, where we basically release both sides and then kind of wedge the spine back into a more normal position using expandable cages and then the rods. You can kind of see it on the left side a little bit. Rod, intradiscal osteotomies versus, I don't know what, VCR or PSO beforehand. What would you have done before, and what are your thoughts on IDOs now?
I mean, I really like IDOs because you can correct the coronal balance, and you're working within a natural disc space of the spine, so the blood loss is minimal. I think, I think it's a technique that's just only going to get better and better.
Yeah, and in full disclosure, this patient did have some consumptive coagulopathy from his polymorbid conditions, but he is working with PT now, no neurologic changes, and these are larger procedures for deformity correction that do carry significant complication profiles, but luckily the patient is upright and walking. And
I mean, usually when we've done these, Jens, I think in this case, this is probably, I don't know what your thought is, that's a rare exception that I've seen that much blood loss.
Yeah, it's actually very unusual, but the patient went into this procedure with a known thrombocytopenia from his underlying marrow disease, and we were probably a little bit slow in responding to that. We had asked for it earlier than our anesthesiologists were willing to respond to, but once they gave the platelets, it vanished. But we had a period where we thought we would stop the case.
Can you go back to the pre-ops real quick, Jerry? I mean, the correction, again, this is a extremely deformed spine. So if you just compare the coronal, this is a pretty significant correction that was done. I don't know what your thoughts are, Bob, but I think IDOs are a game changer.
I like this approach as well, and this is similar to what I do. I don't take both facets, and we've talked about this, but I will do, I used to call the procedure that I do a SPO plus TLIF, and the measurements that I've made on my own cases, we can get about 12 degrees average correction at each disc when you do that. I don't take both facets entirely. I take one facet entirely through which I do the TLIF, And then on the contralateral side, I burr out the joint surface almost completely and test the mobility to make sure that we can compress or distract across it. That I like that just from the standpoint of an additional fusion bed, but I think mechanically it ends up being very similar to taking both facets. So I like that approach here. I guess in retrospect, you don't need to do a fusion at 5.1 because it is already fused. So taking advantage of that, I think probably was a smart idea. The last thing I'd say is the coronal alignment. It's not perfect here, but it's better than it was preoperatively. And I've heard surgeons argue that it needs to be perfectly corrected, and I guess I would take exception to that. I think someone who comes in neutral coronal alignment that you throw off to the degree that this patient now is, does not emerge happy. But a patient like this who comes in worse, that we mostly correct coronal alignment, I think that's something that they tend to be quite happy and quite satisfied with, and at least in my experience. So other than that, I think there's very little to critique here. The lordosis looks much better, and I'm sure the stenosis has been addressed. So
Yeah, stenosis is gone. All right, Jerry, thanks. Let's move on. Final 5 minutes for a quick case presentation that'll serve as a segue. Appreciate your help with the case and the presentation, Jerry, that was done late last night. Last, but certainly not least, Dr. Zakhtataran, and he is going to talk about a final junctional deformity/stability issue. And he's also not had a lot of time to present this because we're in the OR late last night.
Does anyone know how to, oh, there we go. So I have 5 minutes for this. This is a case we did last week. As a 69-year-old female, complaining of worsening back pain and right lower extremity pain. She's been progressively less mobile over the past couple of months. Her husband notes that she has a more progressive forward-leaning posture. She has a very unclear history, and we don't have any records except her words. She's had a history of multiple spine surgeries in 2014, in 2017. At one point, there may have been a fractured rod that was modified in size. But currently, she is with a construct from T9 to her pelvis. This is the earliest imaging studies we have of her, so x-rays from 2009 showing her T9 to pelvis construct. This was in 2019. This is what she came to clinic with us with, so she clearly has a very robust fusion from her upper thoracic to her lumbar spine. You can't actually see, but you can see screw tracks and trajectories all the way up to T4. So she previously had a T4 fusion. You can kind of see it on the sagittal on the far left. She's clearly now fused to T9 and has this unstable segment of motion amidst this robust bony fusion, 2 levels above her fusion at T7, T8. Her cord appears to be draped over this level. So there's some tenting of the cord. If you go back to her exam, she wasn't frankly myelopathic, but she was deteriorating and her posture was deteriorating. But no signs of frank myelopathy.
And we have time constraints now, so this is a horseback rider, Bob. What's your suggestion in terms of how do we repair this? She came from out of state. She's fallen several times from her horse. Would you let her ride a horse? Would you brace her, electrical stimulation, or how would you fix this air gap?
yeah, well, I don't think that observation is the right choice here, given the neurologic issues and the structural issues we're seeing. I think her alignment is good enough below that I don't think I would work hard to change anything there. I think this really becomes primarily a junctional problem and add on to the lower construct. The one caveat being I'm nervous about lumbosacral junction in somebody who's aging and a female who's aging. There's vulnerability to osteoporotic fracture down there, which is really a difficult problem to manage once it occurs. So I would certainly consider augmenting the distal end of the construct as well as revising the upper part. And I think she's got a bit of thoracic kyphosis. You can manage that as part of whatever operation you do. So to me, I'm not sure I would add the pelvic fixation now, but I would be certainly not opposed to it and would be considering adding that as well and leaving the rods that are there and just adding on top and bottom.
So we did not address the lumbopelvic junction. Zach, why don't you take us forward and then open this up to critique?
Yeah, but she does complain of some radicular pain in her bilateral legs, but she does have a robust bony fusion all the way down to her pelvis. Like there's no screw loosening, but yeah, we didn't really address the lower half. But so we took her to the OR last week. We took out some hardware. We cut off the rods just at above T11. One of them we cut a little bit too short, so we had to cut it again. But we did lamies at that site where the cord was tented. We did a posterior 3-column osteotomy, bilateral rise cages, and we re-instrumented from actually T4 to T12. So those are pre-op sagittals, post-op sagittals, CT and X-ray. She did well post-op, said she felt stronger, and was asking when she could get back on her horse.
True story. How much blood did we lose in this one?
A lot. I want to say it was like 2,700. This lady was an abnormal bleeder.
Yeah, we had to go through old fusion mass, so we're very careful, but she did not have to go to the ICU.
No.
Yeah, so.
Is that just one rod or is it?
We did basically end-to-end connectors. We have these new inline end-to-end connector rods, and we basically wanted to have, based on the previous case that we showed, we wanted to have a solid construct above. And one of the technical challenges obviously was to have screws in the old fusion mass, which we spent a fair bit of time navigating. So, but she actually did quite well so far. But Dr. von Halm-Lutterodt, Nick, good morning. Can
Morning,
you hear us now?
sir. Yes, I can hear you all. Yes. Okay. Should I start sharing my screen?
Audio issues with our speaker?
Can you hear me?
Oh, no.
Oh, no.
Can you hear me?
We have a very faint hearing. So let's keep trying. Nick, just start speaking when you are connected. Rod, prior to IDOs, what would you have done with this case? This is obviously, she actually did quite well. She never needed to go to the ICU. She's
Can you hear me now?
Gone home post-op day 2 or 3, I think.
I mean, I think we would have done essentially a T-lift. I think in that case, you know, I think a vertebrectomy potentially, but I think just a standard T-lift.
Yeah, these were real challenges in the past. And again, this was, aside from just working through bleeding brain, I'm not sure it was 2,300 cc's, but we used a cell save, and I think we gave her 1 or 2 units of blood.
Yeah. And why did you stop at T4?
This is her old fusion mass.
Okay.
And I did not feel
Yeah.
that either we had to expand the circle of surgery to the pelvis or to the upper cervical spine. But we had 3 screws on each side that were very solid in the old fusion mass.
You can actually see on the post-op CT, you got excellent correction.
Yeah.
Just just at that one, just doing a 1-level IDO.
Yeah, so I like the bilateral facetectomy. I like to destabilize that segment muscle, control it with a spreader on the opposite side, and have very controlled kind of a release of the anterior column. Make sure that we have enough instability, then insert the cages,
How
expand them
much
very
correction
carefully.
do you think you got at that 1 level? Like 12?
Whatever we
15
needed.
degrees?
I mean, we made it as straight as possible. So are we connected with sound into the room, because we still can't hear our guest speaker?
Can you hear me now?
Nick, I still can't hear you here in the room. I'm so sorry.
We can hear you,
We have
Dr.
our
Lutterodt.
audiovisual
It
technician
seems
is not here
Angela can
today,
hear me. What's wrong
and
with
he is sick with COVID, so our team is
So
trying to
Angela, can you
scramble.
help him out?
Oh, okay. Oh, yeah.
Okay. All right, I'm gonna switch onto my phone and put on a loudspeaker. Nick, good morning.
Morning. Good morning, everyone. How you doing?
It's great to have you here. I'm gonna put on a separate little loudspeaker. Dr. Nick von Halm-Lutterodt. First of all, he's a great guy. I've met him at SRS, NAS, CSRS. For our global audience, he is truly a man of the world. He is a orthopedic and neurological surgeon. He trained at Capital Medical University in Beijing. He did a fellowship in Germany. He speaks fluent German. He worked with Dr. Henry Halm. And he also trained in the Royal Melbourne Hospital in Melbourne. And he's more a neurosurgeon probably than an orthopedic surgeon. As you can see, he does not look like the person that we erroneously advertised in our email blast. I apologize. That's, I think.
It's all right. That's my uncle.
Nick, are you in Minneapolis right now?
Yes, sir.
Okay, now we can hear you over the sound system. So Nick is now switching into the USA, and he is at the Inspired Spine Institute in Minneapolis, and Inspired Spine Health, that is. And he came to my attention with some cool papers. He has published quite extensively, and one of them was to re-explore this fixation that we have on vertebral column resections. And we had some cases selected just from the last week that were meant to serve kind of as food for thought. And I know you had some audio problems, so I apologize that we couldn't hear your opinions earlier. So you heard what we were talking about here. But do you want to go ahead with your talk first? Or do you want to make some comments about deformity reduction in general?
So when we talk about deformities, I mean, we do have the adult spinal deformities, and we do have the adolescent and congenital deformities. Which one are you really referring to, sir?
So you saw that we just did adults here, and this is of the aging spine. Some are rigid, some are flexible. All of them are pretty bad. They're obviously somewhere a different cohort from the pediatric spine, but just pertinent to the cases this morning, spinal deformity is a ubiquitous problem, and trying to correct it is a ongoing battle.
Right, okay. Yes, this is a current conundrum in the spine practice. So what I would say is if the osteotomy that you are choosing to perform is going to benefit the patient with less morbidity, go for it. Just make sure you're comfortable with it. But if it's going to compound the situation or the morbidity of the patients, why do it? So right now we can clearly see a benefit of posterior column osteotomies in correcting deformities without significant morbidities. So I will incline that as my first line. If that will resolve the issue and correct the deformity, I'll choose that over advanced osteotomies. Yeah.
Great. So why don't we go ahead with your talk? You had some interesting comparison studies about more invasive osteotomies versus less invasive osteotomies. And
that's right.
So looking forward to hearing your research experience.
I'm sharing my screen right now. Okay. So as Dr. Chapman has aforementioned, my name is Nicholas van Halm-Lutterodt, and I'm an orthopedic and neurosurgeon trained spine surgeon. My institutions in China included Beijing Chaoyang Hospital and Tiantan Hospital. And my professors were Professor Hai Yong and Xu Yuluan. In Keck Medical Center at USC, I was a scholar with Professor Jeffrey C. Wang. And then I'm currently with Dr. Abbasi Hamid and Sunny Kim at Inspired Spine Health. I do not have anything to disclose. So we presented this was a podium paper at IMAS SRS in April this year. And Dr. Chapman feels this is very practical and pragmatic for the practice and for the global audience in the spine practice to have the knowledge disseminated to everyone. And we compared VCR-based surgical maneuvers with non-VCR-based techniques, which is osteotomies, and other, let's say cantilever, internal distraction and all, to see how to manage severe rigid scoliosis or kyphoscoliosis patients. And these were randomized cohorts within the spine literature. And we looked at complication outcomes specifically. We did not look at the radiographic parameters because we want to see the value-based outcomes between these two approaches. So we know in the literature that severe rigid scoliosis can be defined as curve angle greater than 80 degrees with flexibility of less than 30. And usually when patients present with such significant deformities that are rigid, it's very hard to manage, and sometimes the approach can be aggressive and results in significant neurological deficits and cardiopulmonary complications. Well, some of these patients do have public or social stigmatization where they feel they need their deformity corrected. This actually leaves spine surgeons at a dilemma as to consider the curve correction to be a priority or the patient quality outcomes to be a priority. So it's very beautiful to look at this study and how the results actually came out. So we know that safety is very important when dealing with spine patients. Currently, that we are now moving from, a fee-for-service model to a more value-based model in healthcare delivery. So this is something that we should look at. So the hypothesis here is to investigate the perioperative complication rates between VCR-based and non-VCR-based techniques in managing severe rigid scoliosis patients. And it was a systematic review and meta-analysis. As I've aforementioned, we know of certain type of osteotomies, and I would basically simplify it by using the Schwab's classification of posterior column osteotomies and 3-column osteotomies. We have the SPOs and the Ponti, and then we have the PSO, and then we move to VCR. Now, when we talk about SPO and Ponti and PSO, that is pedicle subtraction osteotomy, when we perform these osteotomies in patients with significant rigid deformities, we can get up to about 15 to 45 degree of correction at a level. So this is something that VCR can overcome. With VCR, with just one resection of the vertebral body at the apex, you can assume correction of about 60 degree. So that is one of the advantages VCR offers over the other osteotomies. But the question is it worth risking the complications that patients will have, or risking the patient's quality outcomes with the osteotomy that you're going to perform if you can achieve satisfactory outcomes with non-VCR approaches? And sometimes if you are not familiar or very comfortable with VCR, there's no need to do it if you're comfortable with posterior column osteotomies, and you can still achieve satisfactory rate outcomes in patients with lesser complication rates. So this is something we are looking at right now. So we did a comprehensive literature review and meta-analysis from 2000, all published studies from 2000 to 2021 September. And we chose randomized studies that compared VCR-based versus non-VCR-based techniques for treating severe rigid scoliosis or kyphoscoliosis patients. Only English articles were selected, and we made sure that within each cohort that compared the outcomes, there were greater than or equal to 10 patients. And I've already mentioned that we know about the criteria for defining severe rigid scoliosis, and we talked about greater than or equal to 80 and less than 30% flexibility on bending. We also looked at papers that basically published their complication rates with at least 2-year minimum follow-up. So this is very, very defined criteria for selecting what we want to look at and to analyze the results. And we computed the odds and confidence intervals for data that were analyzed. What did we look at during the method of assessment? or evaluation, we looked at the perioperative cardiopulmonary events, and we also looked at the dural tears, nerve injury, significant intraoperative monitoring changes. I grouped these together because they were related and close to the spinal cord. I just wanted to make sure that we have something that is neurologically related to make sure we can see the clear pattern of the impact of osteotomy on neurological outcomes. And also, we looked at surgical site infection and wound complications, implant or cage-related issues, immediate post-operative intensive care unit admission following the surgery, and then reoperation rates. We also looked at other clinical variables that included mean operative time, estimated blood loss, and hospital length of stay. What did we get after we analyzed the data? So we realized that there were about 174 patients in total, and of which 52% were managed with VCR-based. So clearly there is a tendency for a spine surgeon who is familiar with deformity management to choose a VCR approach over a non-VCR approach for managing such cases. And we also realized that the incidence of dural tears, nerve injuries, and significant intraoperative neuromonitoring changes was significantly higher, with odds ratio of about 6.78 in the VCR-based technique compared to the non-VCR-based technique. Overall surgical incidence was higher in the VCR-based group, but not statistically significant. I have some forest plots here I would like to show to everyone. As we can clearly see, we see that with the perioperative cardiopulmonary complication outcomes, we had 10 events in the VCR-based, and we had 5 events in the non-VCR-based. However, it's not significant. The dural tears, we have 28 events and 7 events in VCR versus non-VCR respectively. And that's like ×4, okay? And then we also see surgical site infection with complications, but there was no statistically significant difference between the two. Then let's look at implant and cage-related issues. We had 4 here, and we can see post-operative ICU admission, we have 2-1. Operation within 2 years following surgery, we had 2-0. They were not significant. And we also see that overall surgical complication rate resonated more in the VCR compared to the non-VCR, statistically not significant. However, we can see, let's go back. The only thing that we see here to be significant is the neurological complications. And I believe no one has a doubt about that. It's kind of like expected based on first-hand experience with what we see in clinic. So this trend of this illustration here, we can see the non-VCR here, VCR, overall surgical complications. With overall surgical complications, with non-VCR-based osteotomy techniques or maneuvers for managing severe rigid scoliosis or kyphoscoliosis, there is a decrease in overall complications. You can see there is a decrease, the slope is very clear. And then when it comes to nerve-related or neurological complications, we can see a very high incidence in the VCR-based group here. We also looked at mean operative time. The mean operative time, we can see that it favored the non-VCR, but was not statistically significant. Blood loss, we know that VCR is significantly associated with increased blood loss. When we have blood loss, patients do not do well, which we are very familiar with, right? So the blood loss favored the non-VCR, which is also expected. And with the hospital length of stay, it kind of like favored VCR a little bit, but there was still no significance. So what is the conclusion? Findings from this study clearly indicate that overall, both VCR and non-VCR surgical maneuvers for correcting severe rigid deformities are comparably safe, okay? And regarding complication rates because there was no significant difference between the two. However, VCR-based is significantly associated with increased neurological morbidity. That includes dural tears, nerve injury, significant intraoperative monitory changes that can result in paralysis following surgery. So this is during and following corrective surgery. We have to understand that the study clearly indicates that both VCR and non-VCR surgical maneuvers are statistically comparable, but clinically, we should be more concerned about the value-based outcomes of our patients. So not all patients will require VCR, so we cannot do a VCR for severe rigid deformities. If posterior column osteotomies, like multiple asymmetrical Ponti osteotomy can fix the problem, we can apply that. If it's multiple Smith-Peterson osteotomy, we can apply that. If it is two-level pedicle subtraction osteotomy, we can apply that and minimize the neurological morbidity in our spine patients. So VCR-based technique was associated with 6.78 times, almost 6.8 times high in neurological complications compared to non-VCR-based techniques. And when I computed separately the average correction rate, we could see that the VCR-based had 53.4% correction of major curves, and the non-VCR had 52.3 correction of major curves within the two cohorts. So there isn't a big difference in achieving correction and alignment when you use these two approaches. So that's it. Thank you.
Thank you. Great talk. Can you go back to your results slides, to the forest plots? So a couple of questions. So first of all, I think this is a long overdue study, and I really congratulate you on having taken this on, and this looks very nice. My question to you is in terms of the group similarity, the demographics of the two comparison groups, how similar were they in terms of demographics, like curve types, rigidity of curve, et cetera, or geography of curve, like thoracic versus lumbar or thoracolumbar junction?
Okay, so they were very similar because these were like thoracolumbar curves, mostly thoracolumbar curves. And with one study, they included idiopathic, adolescent idiopathic, I think just adolescent is idiopathic scoliosis patients. That is the fourth study, but mostly were thoracolumbar curves, yes. Thoracic and thoracolumbar curves. And
So demographics, can you go to the length of stay again?
Which one?
Go forward in your results section. Maybe go back a little bit. So were all of these papers from the People's Republic of China?
Frankly speaking, yes. Yes. So the first one was Ren et al. In 2014. The second one was Hanwei et al. In 2017. So that the first one compared AP-VCR versus anterior release with posterior internal distraction. The second paper was in 2017, Hanwei et al., and it was PSO versus VCR, Schwab grade 4 compared to Schwab grade 5 posterior column osteotomy. And then the third paper in 2017, it is Zhou et al., also from China, AP-VCR versus AP-SF. That is anteroposterior spinal fusion. And then in 2019, we had from Hai-Yon's team, multiple asymmetrical Ponti osteotomy versus posterior vertebral column resection, PVCR. So these are all from People's Republic of China. Yeah.
So the point there is that when we look at length of stay or blood loss, obviously patient demographics, patient size, and the culture of hospital stay apply very heavily and can't be translated one-to-one to other cultures. Like body size does matter relative to
That's right.
blood loss, and length of stay is very heavily related to the societal expectations. For instance, you practiced in Germany with the famous Henry Halm. The length of stay in most German government hospitals is much longer than what we have here in the US.
Right.
and same also in Japan, for instance. I've been to the People's Republic, and I think it's a mixed bag there between the government and the more private institutions. But again, length of stay is something that's very difficult to extrapolate from one country to another. Would you agree?
I totally agree with you. Yes. Interestingly, these are the papers I was able to retrieve from the spine literature, which means that I would encourage spine surgeons around the globe to basically publish studies comparing VCR versus non-VCR approaches, and we can have an updated results to generalize outcomes in future. Yeah.
I couldn't agree more. I thought your paper was really hit a sweet spot because this has not been really looked at before in a larger scale. And I too was surprised that all the papers came from the PRC, and they obviously addressed a very important topic. And I thought your introductory statement of saying we should choose the least invasive approach that gives us the maximum benefit for patients makes total sense, but it's again not been really scientifically looked at before.
That's right.
But whenever we have a paper where there's one center, it's not even country dependent, but one center that dominates the others, we have to be careful that the local culture of the center or the local medical society standards of care may influence the results reporting. And again, I'm always worried when one country or one medical system tries to extrapolate from another one without reflecting on where there are differences and expectations. So that's the main point, but intuitively it makes total sense. And I think the dural tear and the neural change aspect is a huge factor. What was the average, I missed that somehow, the average age of the patients in this collective? How old were the patients in the two collectives?
Usually the age ranged from 18 to about 25. Yes.
Great.
Average age. Yes.
So in your own practice, what leads you to determine the more invasive versus less invasive deformity correction procedure? Is it flexibility of the curve? Is it geometry? What are some of the key variables that you can share with us in the audience that influence you towards the less invasive versus the more invasive surgery?
Okay, so for, let's say you have a severe kyphotic deformity, okay, if the kyphosis is really significant, greater than 90 degrees, and the curve is rigid, and you can perform VCR at the apex to reduce the kyphosis, or you can also perform multiple posterior column osteotomies, like multiple asymmetrical ponti osteotomy to reduce the kyphotic deformity. It depends on the location of, if it's mainly thoracic, you can just perform ponti, just like we see in ankylosing spondylitis. You can use multiple ponti osteotomy to correct the deformity. Whereas PSO, we can use that to correct both anterior and posterior deformities, coronal and sagittal deformities. So it depends based on the surgical experience that the surgeon may feel comfortable with and may have or been exposed to. Yeah.
I think those are very important points. And obviously age of the patient, general fitness, bone density is a big factor. Prehabilitation, like Dr. Babican pointed out, is a very, very important factor. Do you believe in undercorrection versus overcorrection? You know, this whole SRS, ISSG thought of older people should probably not be overcorrected, or we should undercorrect them a little because they want to hang forwards. Is that something that factors into your equation?
Yes, I think overcorrection is not good, because sometimes overcorrection can lead to hypokyphosis, okay? And the patient may not actually be well aligned following overcorrection. So it's very critical when correcting the patients, is how much the patients can tolerate. We should always bear that in mind. And that is very important for, better clinical outcomes following surgery in patients, especially with deformities. Yeah.
Great. Well, we're at the 8 o'clock hour here on the West Coast. We certainly thank you for joining us. Are you in Minneapolis right now from judging on your wall clock?
Yes, yes, sir.
Well, we're hopefully going to see you much more often here in the US, obviously, and at SSF. And
Sir.
again, congratulations on picking up on this topic and presenting it so well. And wish everybody a very happy and healthy summer here. And until next time, take care. Thank you.
Thank you all. Thank you all for listening.
All right, rough start. Here we go.